Hello, everyone. It's Thursday, 8 p.m. And obviously, this means it's CCI time. CCI's webinar has been an integral part of our academic journey. And I'm talking about all pulmonologists from India. And, not only India, I think I slowly have to, go global because I'm sure CCI will slowly start going global. Now, we are in this middle of a COPD webinar series, and this is the conclusion of COPD webinar series. And this is a very, very interesting, very innovative talk, which is smart care in COPD. Can we use smartphones? Can we use AI? Can we use technology? Can our practice be better as far as managing COPD is concerned? It's a brilliant topic, innovative, something which we will not probably get in textbooks. And believe me, that is what CCI is for, because over here, so many topics are discussed, which are not conventional, which we do not get in textbooks. So many people to thank at the outset. Let me thank Dr. N.H. Krishna sir, Dr. Narayan Pradeep sir, Dr. Ashish Dubey sir, Anil Maske bhai, my very favorite, the lovable Dr. Jaykumar Chetty Garu, and so many people who go and who make this webinar a huge success. Now we've got a lovely, we've got a pan-India representation as far as the panelists are concerned. I'll start with Dr. Aditya Chawla, who's actually from Delhi, but believe me, right now, he is so committed to CCI and he's so committed to academic discussions that he's actually joining us from Florence, where he's pursuing a fellowship. We've got my favorite Dr. Jaykumar Mehta, who's coming from Ahmedabad. Dr. Devijyoti, who's joining us from Raipur. Dr. Sindura Koganti, who's joining us from Chennai. And of course, mere yaro ka yaar, Dr. Mahesh Jansari, who's joining us from Kalyani in West Bengal. If this isn't pan-India representation, I don't know what is. This is exactly what CCI stands for. So today's discussion, we're going to divide it into two parts. The first part is going to be two brilliant talks, which will be delivered by Dr. Jaykumar Mehta and Dr. Mahesh Jansari. The first talk is going to be Smart COPD Care, which will be delivered by Dr. Jaykumar Mehta, sir. And this will be followed by the role of tele-rehabilitation in today's digital era, which will be given by Dr. Mahesh Jansari, sir. Let's go ahead, listen to both these talks. And after this, we will have a lovely, in-depth, innovative, incisive panel discussion.
So thank you so much, Kapil bhai, for the kind introduction. Now let me just brief about today's topic, that is smart COPD care, use of artificial intelligence, smartphone apps, and telehealth. It is a relatively new topic, and I think it will be enlightening for all of us how fast the technology is progressing. But before delving into this, first and foremost, a vital question: why digital health for COPD? The answer is that first, we have very high burden of COPD in India. India has the second largest number of COPD cases globally, which accounts for around 50 to 20% of COPD deaths. Plus, this type of exacerbations, there is high out-of-pocket expenditure and loss of productivity. It literally financially burdening to many of our patients. The major contributors are biomass fuel exposure, air pollution, undiagnosed asthma, COPD overlap, and smoking tobacco use. And AI and digital tools can help in early case detection, risk stratification, symptom tracking, as well as it can reduce follow-up visits, early intervention, and reduce the exacerbation, which leads to the hospitalization. So this is one very powerful indication to incorporate digital health for COPD. Second is, as we all know, there are shortage of trained pulmonologists and even spirometry access. Even the primary care physicians, they often lack access to quality spirometry. And even if available, it is underutilized due to lack of training. So smartphone-based spirometry and AI interpretation tools can bridge this diagnostic gap. Third is, there is very high smartphone penetration and low healthcare access. Like over 600 million smartphone users are there in India. And large number come from tier 2 or 3 cities and rural areas. So AI-empowered mobile apps like Hi-Fi and Google Health, which we'll be seeing in next slides, can get cough detection, allow passive and non-invasive symptom monitoring at scale. So it makes remote COPD monitoring, digital pulmonary rehab, and AI-driven alerts feasible even in the rural settings. Fourth is integration with the national programs like Ayushman Bharat Digital Mission and National Program for Prevention and Control of Cancer, Diabetes, CBD, and Stroke. They are revolutionizing the digital health, and we can have very good COPD platform which can be feeding this data into these missions for surveillance and health planning. Fifth is this technology is low cost and scalable, and it is perfect for the low and middle income countries. And because India is diverse when it comes to the language and literacy adaptability, the AI and digital health platforms can adapt it into the different narrations, like in Hindi, Gujarati, Tamil, etc., for the semi-literate patients. So with that background, we all can agree that yes, definitely there is a need of digital health for COPD, which can early detect the patients, which can track the symptoms, which can provide tele-rehab, as well as worsening of the symptoms and prevent the exacerbations. But then how we can do it? First, let's go into the diagnosis. It all starts with cough sounds, and hence we all know power of the sound when we are in training. Sort of other, we always see the patients coughing, and we describe the cough in different types. Let's hear what Dr. Sandeep Salvi sir
has
is
pulmonary
telling us.
fibrosis, or if the patient has pulmonary edema, or if the patient has pneumonia, you get a very classical type of cough. The patient does not take a deep inhalation before he or she coughs, and the cough is repeated multiple bouts of weak cough. Let me demonstrate that to you.
So due to shortage of time, I could not share entire video. But I think we all get the idea that different types of diseases have different types of cough. In this video, sir has beautifully demonstrated the cough originating from the distal airways. Then there is a different sound of cough which originates from the proximal airways, different sounds coming from the epiglottis and so on. And hence it's the power of human ear where we can differentiate different cough sounds and we can diagnose the patient similar to that way. AI also has the ability to discern the different cough sounds. So this is one company, Hive AI, which gives a Play Store app known as Cough Pro. How Cough Pro works is that it detects the event. First, you need to switch it on in your smartphone and keep it on nearby your body so that it can detect the cough. There is an event detection where the AI is designed to detect cough. Then it extracts that sound and then it classifies it. But for that, you need to have real-time on device. So how does it work? That when we see our patients, we ask for how about your cough? There's subjective improvement, but we don't have really objective idea about that. And this is what Cough Pro says, that it actually helps us in real time tracking the cough symptom score. However, it doesn't differentiate between the diseases of different types solely based on different type of cough. Still, it is very useful because it gives lot of information about hourly coughs. Then you can have hourly, daily, weekly or monthly cough charts. So you can see how much the patient is doing good or worsening. Then there is a cough rate per hour. And also there is cough trend, whether the cough is decreasing or increasing. Then there are cough bursts or bouts of cough which it detects. Also, it gives idea about how to manage the cough with involvement of the education and techniques and triggers. And then there are videos on how to cough to control the coughs, and these are some education how to improve the quality of life. Coming to another very good tool called Here by the Here Cough Tracker by Google. HERE stands for Health Acoustic Representation. It is a deep learning foundation model created by Google Health. It learns rich acoustic patterns from large-scale audio data, over 300 million recordings, including coughs, breathing, and speech. So it trains in a self-supervised manner. And the input is a raw audio where the output is a dense feature embeddings that represent nuanced acoustic properties. As of now, it is still in R&D and not publicly available, but yes, it can discern between different type of cough. So how it is, how does it work? So once Here transforms audio into robust acoustic representation, it collects label data, extract the features, train a lightweight classifier and validate whether the classifier can differentiate diseases. And their internal study shows that there are different acoustic signatures from COPD, asthma, pneumonia, and TB. And just based on that, we can diagnose that this patient may have TB, COPD, like that. So I think this is going to revolutionize the COPD symptoms, how we are looking and differentiating different diseases. Then again, very important training when we get enrolled in the pulmonology teaching program is lung auscultation sounds. So obviously we have characteristics imprinted in our brain, the way we are using our stethoscope. But actually you can quantify it in a technology called phonocardiogram. As you can see here, the tracheal sound is having different pitch and frequency. And so on the vesicular, bronchial, stridor, wheeze, rhoncus, fine trickle, coarse crackle, pleural fiction rug, and squeaks. And you can see there are different signatures on the right hand side where you can see that phonocardiogram shows and discerns them. And based on that, there is now availability of our indigenous Indian made, I was saying that is a digital stethoscope. There is a beautiful device which can transform any simple stethoscope into a digital stethoscope where you can enhance the volume up to 60 times, and there is also noise cancellation feature given in that. So this is how it incorporates from the diaphragm component, and with the earpiece component, just have to incorporate into the simple stethoscope, and then it can transform and give it the digital signature. When you connect this with the Bluetooth app, which when you purchase this device, they give you the login ID. And then as you can see on the right hand side, you can have the different phono signature. Based on that, you can have an auscultation report, an artificial intelligence prediction, and also you can share to the concerned consultant. So suppose as of now, I'm sitting in Ahmedabad, and if in remote area like Bhuj, one of my patient is having some problem, and if a nearby healthcare worker just puts the stethoscope and sends me the signal, I can be able to diagnose whether the patient is having increase in crackles, or whether there is wheezing, or whether there is rhonchi, and I can just coordinate with the healthcare worker there and treat the patient sitting in Ahmedabad. So I think this is a very good device which is incorporating. Coming to the AI radiology platforms. So we'll not spend much time because of on this because of short of time. So as we can see now, Cure AI is doing wonderful work in picking up lung nodules based on the X-rays. It can also detect hyperinflation as well as bullying. Another is Unity Insight. Then on CT, personally, I'm using Imbio, and I'm very much happy with the performance, the way it detects the ILD. It differentiates into the honeycombing, ground glass attenuation, reticulation, and hyperlucency. And based on that, we can differentiate whether the patient is having increase in ground glass, increase in the reticulation, increase in the honeycombing, and it gives percentage-wise results. And I think it has done wonderfully in many of my patients. And then again, Siemens CT AI platform is there, which can all detect emphysema and give you the early prediction that this patient is having emphysema and COPD, and we need to treat them. Coming to different type of smartphones, there are plethora of smartphone apps when it comes to COPD management. Few of them I will be sharing on this platform. First, which I found the interface very good, is COPD Pocket Consultant Guide, where there are two interfaces. One is a healthcare, and then there is a pocket guide. As you see in the patient view, daily log, goal setting, wallet card, inhaler nebulizer videos, exercise videos, COPD 360 social, where you can connect with the like people, COPD digest, and many more things are there. So it gives you the symptom scoring like HomeCat scoring. It gives you goal setting like cleaning, whether you can be able to do this or not, making my bed. So it gives you goal setting. And then you have wallet card stating that you are up to date with the vaccination. One more which is freely available, and more than 10 lakhs download, what I saw on the Google Play Store, was Breathe Free Lung Health app, which is powered by the CIPLA, where it is diverse range of services they are giving and doing wonderful work, whether yoga sessions, physiotherapy sessions, dedicated health coach, personalized diet plan, multiple slots available, inhaler device education, and then they give you education, live technique check, dosage tracking, and then they give you the dose reminders. And I think it's wonderful app if it's installed in a patient with COPD. But not only that, there is Hi-Fi, the cough tracker, cough and wheeze tracking apps, like inhaler reminders, smart inhaler apps like Propeller Health, Kokero Health, My Air Coach, which gives you timely medication reminders, usage tracking. Then there are breathing and pulmonary exercise apps, which guides pulse sleep and diaphragmatic breathing, daily rehabilitation exercises with customized intensity. Then there are step counters or activity trackers like Google Fit, Apple Health, Samsung Health, which monitors your daily physical activity. Then pulse oximeter integration, which is Bluetooth-enabled pulse oximeters, which tracks your SpO2 and pulse rate. Then environmental alerts like air quality and weather indices like Suffer Air, AQI India, which notifies the air pollution and gives you guidance whether you can perform outdoor activities or not. Then there is nutrition and weight monitoring devices like MyFitness, Yazoo, which helps COPD patients for muscle wasting or obesity. Sleep monitoring apps, which identifies overlap of COPD and obesity, mental health and anxiety support, which is common in COPD patients to address the comorbidities and which can address the anxiety and depression in those patients. Spirobank and digital spirometry app, where you can connect with the Bluetooth with the Spirobank alert like Mir, and then you can actually demonstrate and document that. And then there is emergency contact and SOS switches, and finally telemedicine and remote monitoring platforms like Practo 1mg and all, which enables follow-up video consults and prescription, and it encourages adherence and early reporting of symptoms. Finally, coming to third part of my talk, that is telemedicine or teleconsultation. So we do routinely teleconsultations, but we need to adhere to the guidelines for practice of telemedicine in India. This is 2002 updation. I'll just give a brief review because it itself is a big criteria, big talk itself. But there are 7 key elements of a telemedicine consultation. First is a context. So whether the patient is seeking for a routine non-emergency type or it is an emergency type. So it comes first and foremost, it's a teletriage. Whether the patient needs emergency or not, and whether your center is equipped to give this emergency services or not. Second is identification of RMP, that is medical practitioner and patient, because many times you don't know who the patient is. Somebody is a proxy and the patient doesn't know that you are a doctor. So introduction of yourself and identification of that this is the patient is very important, and you need to verify whether you need to do Aadhaar card verification. It's based on your risk appetite, whether you incorporate that or not. Then there is mode of communication, whether this is audio like on phone, like whether this is audio visual like some video platform, or whether this is only text, simple text message or a text WhatsApp message. This is very important because you can prescribe certain medications in certain way only. Fourth is consent. If the patient initiates the teleconsultation, it is implied consent. But if you are calling them, then it's an explicit consent where you need to mention, you need to have a consent for the teleconsultation. Fifth is type of consultation, whether it is a first consultation or a follow-up consultation. Because some medications you can only give in the follow-up, while some medications you can give in the first consultation. So it's very important that you document it's a first consultation or a follow-up. Ideally, you should see the patient after 6 months. Every 6 months. That is what the recommendation is. Sixth is you need to describe patient evaluation in detail and give a clear-cut patient management and whether the patient requires admission or not, when to consult, and your signature should bear on the consultation. So again, like there are certain list of medication. We can describe them list O, A, B, and prohibited. List O medications can be given in any type of consultation to any patient. List A can only be given on the video consultation. Again, list B is only for the follow-up patients, and O is prohibited. In brief, as you can see, cough suppressants, decongestants, expectorants, antihistaminics, and smoking cessation drugs come under list O, while inhalers come under list A. So you cannot prescribe inhalers just by the text or audio consultation. You need to see the patient and if preferably examine the patient nearby. So I'm giving a sample teleconsultation which is done by me. As you can see, it mentions the date, it's a follow-up case, the diagnosis, last seen, when and which mode. Now I am saying in which mode, how was it, what are the examination findings, the vitals at whom I have written, because I don't have the real-time track. Then advice, and as you can see, it bears my signature. So with this, I end my talk. So the take-home message is that initially it was only doctor, patient, and a physical examination. Then reports came in, whether there is form of a radiology or pathology. And now we are facing more and more digital inputs. And I think this is going to help us rather than antagonizing them. It's better that we soon incorporate them in our practice. And that's why CCI is doing this seminar. Thank you so much for your patient listening on this important talk. And now I'll hand over this baton to Dr. Mahesh for a wonderful talk on tele-rehabilitation. Thank you so much again.
Hello, very good evening. First, I would like to thank Dr. N.H. Krishna, Dr. C.V.K. sir, and the entire CCI team for CCI webinars. And especially thank you for giving me opportunity and selecting such a very unique topic of artificial intelligence in COPD. And I would also like to thank Dr. Jay. He has given a very wonderful elaboration on AI in COPD. And I'll be speaking on tele-rehabilitation in COPD. So what is tele-rehabilitation? As the name suggests, it is a delivery of rehabilitation services via the digital platforms. And all of us know the different modes, like it can be given over the voice, by phone call, by voice messages, by video calls, as well as sharing the videos on the email, as well as by the mobile applications. And there are many web-based programs also. As all of us know that pulmonary rehab is a very important part of COPD management, and there are some of the factors which negatively impact this rehab program. And these are like patient-related factors like symptoms, poor social support, patient have financial issues, time is a constraint. There's a long waiting time at the rehab clinics, as well as there are some psychological factors which contribute negatively. As well as there are some physician-related problems like lack of facility, and one very important thing is less perceived importance of rehabilitations. And we have seen that during the pandemic, COVID pandemic, due to fear of contracting infection, many of the people did not come to a rehab clinic. So these are the factors which negatively impact pulmonary rehabilitation. And to overcome this problems for pulmonary rehabilitation, tele-rehabilitation is a very unique concept. And there was one study done in 2023. Around 15,000 patients took part in survey, and it has been seen that pulmonary rehab was given only to 48% of the patients. 43% were they did not receive any pulmonary rehabilitation, and even the 9% of the patients were not aware of pulmonary rehab at all. 30% of these patients, they have this problem occurred due to they did not have time, there were lack of equipments, and there was a long wait list. So to overcome this, tele-rehab is a very unique concept. Even the GOLD guideline 2025 says that to date the most studied telehealth modalities in COPD are pulmonary rehabilitation and self-management interventions. Even a clinical practice guideline reported that the tele-rehab can achieve similar clinical outcomes as compared to a in-person pulmonary rehabilitation. Even they recommended that a stable COPD patients should be offered the choice of pulmonary rehab. It may be in-person as well as tele-rehab, and it has a very strong recommendation with moderate quality of evidence. There are various delivery platform of this tele-rehab, as I mentioned earlier, like a video conferencing by phone calls, or website with telephone support, as well as the mobile application with feedbacks. There are some centralized hub for the people to come together online and discuss about the COPD-related issues. For this tele-rehab, we require certain kinds of gadgets, and some gadgets are very important from a patient's point of view. That's pulse oximeter, wearable fitness trackers, as we know about the smart watches, and it can track heart rate, steps, oral physical activity, and sleep-related issues. Smart inhalers, even a physician can check the compliance, and the patient can get a reminder of the inhalers also. And overall, this improves the patient compliance. There are some portable spirometers, as Dr. Jay had mentioned, and they measure the spirometry, and data is directly sent to a healthcare provider. There are some health apps and with which we can manage many of the things, and they are very useful from the patient's perspective. Some exercise tools like resistance band, cycle ergometer are best if patient is having at home. Some mobile application and platforms are there. I do not recommend personally any of this mobile apps or platform, but this is just for our viewers that what are the things that are available in the market. So one is that Kaya Health, it provides the personalized rehab programs. There are some COPD apps also, and then it targets the exercise education and as well as the symptom tracking. There are some apps like a My COPD app, which provides the educational modules, symptom monitoring, as well as it guides the patients for the certain exercises. There are many more health apps and platforms. The few of them are like Propeller Health, that React Pulmonary Rehab, and there are some US-based platforms like Rehab Gurus as well as the Welllinks. So these are the certain things when we are thinking about this tele-rehab program. Then if we put emphasis on certain things, I have put into in a stepwise manner. And in a step one, you just first need to assess the patient. And as we know that one approach does not fit to all, so we have to make a tailor-made approach, and it begins with the assessment of patient. There are some of the physicians, they use a hybrid approach, that the first consultation they do in person and the subsequent consultation, subsequent rehab follow-ups they can do online. So first we have to assess the patient's tech literacy, and does he have access to internet or not. If he doesn't have an access to internet, we can have a close relative with staying with the patient. If he is aware of it, then this is a very good option. Then once this basic assessment of tech literacy is done, we can move towards the exercise program creation. And this exercise program creation is a multidisciplinary team approach where the physiotherapist, respiratory therapist, and it also requires the IT support. Then once these basic programs are set, then we need to monitor. We have to set the monitor protocols for symptom as well as vital signs. And this can be done with the help of pulse oximeter, spirometer, smartwatches, mobile apps, as well as certain web-based programs. Then subsequently, we can go for the regular checkups and adjustments, or there is some improvement or some increase or decrease in rehab exercises, rehab methods, etc. And once everything is done, outcome can be assessed by the 6-minute walk test and FE1 and quality of life. So we'll see what is the reality of tele-rehab in a day-to-day clinical practice. I personally do not have an access to this tele-rehab as of now. I have spoken with many physiotherapists, many physicians, and most of them have mentioned that they are not doing tele-rehab as of now. They used to do during the COVID period. However, I could find one program by Dr. Mrinmay, and the program is the pulmonary rehab, and this is India's first exclusive tele-pulmonary rehab center, and this is situated in Mumbai. So I would show you what are the glimpse of this program are that they have set a very strong screening protocol, and they have even set up the measures for some of the emergencies which they can encounter. Here we can see that patient is being interacted by a physician, Dr. Mrinmay, and then their team is providing exercise protocols, exercises to a patient. And they have also even incorporated some of the unique programs or unique activities. Some of them are oxygen therapy in lung patients, like single lung and pulmonary yoga, and they conduct all these online programs so that this patient have a very good compliance, as well as they can cater the patients on telerehabilitation. However, this was the positive side which I have mentioned, but the goal 2025 itself mentions that the evidence base is still evolving and best practices are not yet established at this time. And it is due to a lack of standardized delivery platform. The tests performed remotely, they do not know whether they are doing it accurately or not. Information suitable variations in components and the timing of interventions, no data is as of now available, and evidence is day by day building up. Even one of the RCT has showed that telemonitoring did not change the hospitalization or the exacerbation rates in people with COPD. So with this, I can say that this is a very unique approach for a patient who cannot come to a hospital, especially in scenario of pandemic-like situation or some social issues. They can avail the facility of pulmonary rehab by by online method, and it is effective and it is evolving. So let's see in future what is there for us. Thank you.
Amazing two talks. I would really like to thank Dr. Jaykumar Mehta and Dr. Mahesh Jansari. This is a test match, and I think we've had the two best openers, who have begun the innings. But as I mentioned, this is a test match, so we've got a long way to go. So let's start with the panel discussion. And before I start asking questions, I just want to ask all the five panelists, are any of you using AI right now in COPD management? See, I am not, but are any of you using any apps?
So, Kapil, we are starting to use because nowadays those smart inhalers are coming. Then there is small device that is smart breath analyzer which is coming. They have kept it the clinic. We have tried. I have tried with some patients. It gives out the FEV. It gives out the FEV1 in single blow, and it comes in your mobile. So these kind
Perfect.
of applications are working in your clinical practice. You start embracing them. It is good till when you will fight.
Perfect. So I think we've got a mix in our panel, people like me who are absolutely not using anything. And, you've got better technologically, more advanced people, like Dr. Aditya and all who are using it. So it gives a good mix of experience and let's say an innovative, talk or thought process, which will come out in this panel discussion. Now, Dr. Aditya, since you started, I'll direct the first question to you. See, Dr. Jaykumar in his talk laid out some very scary statistics of COPD, how it's going to increase mortality, all of this. Obviously, all of us are struggling with COPD because we are somehow not meeting the requirements of managing COPD. In the current clinical practice of your practice, in what area of COPD managed do you see that there will be a role for technology?
See, first of all, I would like to congratulate Jay for an elaborate talk which he gave on so many applications which he researched. I think he has researched it through and through AI with COPD, and he has updated his knowledge the most right now because way beyond he presented. So my take on it on AI is that technology, AI, mobile applications, these are here since 2012 2010 we are feeding our data slowly to these applications. Now these applications have become very smart with us, and they are going to promote early diagnosis, personalized treatment to the patients, as we have already feeded the data of the patients to the AI applications. So in near future they are going to reduce the hospitalizations, increase the timely interventions, predict respiratory failure. One of the slide which Jaya showed, remote monitoring, which predicts analysis of exacerbations, and it tracks the disease progression. So there are so many things that are going on. One, I would like to quote a study, COPD Predict is going on, which is doing this remote monitoring. Then enhanced diagnostics, which is being carried out by Srivastava et al. In 2021. They have published the paper. So they have analyzed the audio inputs of the cough, like Dr. Sandeep Salvi showed. They are using those audio inputs to distinguish the different lung diseases, and also the electronic health records which we are using day by day in our hospitals. We are seeing OPD patients in and out. We are feeding the data to the computer. So when this data record will be prepared, this is going to be of great help to us as clinicians to analyze the deterioration of the FEV1 values, the deterioration of the DLCO values, and prediction of the exacerbations. Moreover, they are even trying to distinguish the population of the patients based on phenotypes. So, study going on in Theorna right now in 2025. They are having the, what do you say, not published still on the net, but they are saying they are doing a phenotyping and the stratification of the population of COPD. And there are many companies like Wiz.ai who are collaborating with pharmaceutical companies like Sanofi and Regeneron, which are generating the vaccines and doing the care coordination by analyzing this health record data. And AI is able to identify and manage the high risk patients, and even they are able to notify the care protector of the patient, like we doctors who are having the database of the patients. They are giving us an ultimatum on our applications that this patient is going to have this kind of a exacerbation, patient's heart rate is this, and they are giving the alarms. So many things are going on. So if we embrace AI as a tool for our clinical use, it is going to help us in near future.
Okay. Thank you, Dr. Aditya. I think you used lovely words. We need to embrace AI, which is quite
Yeah.
evidence with your talk. And, in your talk,
We can't fight it.
you spoke about population stratification. So I would like to
Yeah.
get Dr. Devi to this question. See, Dr. Devi, clinically, we are struggling as far as screening programs of COPD is concerned. We wait for the patient to actually come to us. It's more of an active approach rather than a passive screening. Do you think AI or technology can somehow bridge this gap and be like a better screening tool?
Yeah, thank you, Kapil, for this question. At the outset, I would like to thank CCI for this opportunity. And this is a wonderful question because in recent years, we have seen that diagnosing early COPD is a challenge. And the earlier we diagnose, the better is the outcome. Because when patients come to us, most of them are already in late stages of COPD and are difficult to treat. So early COPD among at-risk individual screening is very, very important. And I think AI can help us with that, especially it can assist in diagnosis. As we have already discussed, Dr. Jay has also elaborated, it can help us in interpreting and diagnosing spirometry or PFTs. We all know that having a good spirometry and interpreting it is not very common, especially in India. Also, AI can help us with the analysis of X-ray and CT images to identify early COPD changes or to quantify and qualify emphysema. Also, it can pinpoint the change in the lung structure.
Okay.
As already we have also known, it can help us with auscultatory findings in patient in at-risk individuals, like someone is smoker or with increased age, recurrent chest infection. In all those patients, if somebody is a healthcare professional is sitting in a peripheral location, he can send us the that screen of auscultatory findings, and we as experts or pulmonologists can interpret and categorize the patients or the individual.
Okay.
So the AI can integrate and analyze the data for early diagnosis and screening and can build predictive models.
Okay. I perfectly agree with you. We need patients to come to us quite early in their disease, and definitely AI will have a role. And as you rightfully mentioned, smokers, screening and the X-ray, that is definitely, going to be a part of it. Now, because you mentioned smoking, I'm going to ask Dr. Sindura the next question. Now, we did recently have a CCI webinar dedicated to smoking cessation. It's an integral part of smoking related COPD, all of us know, and in fact, smoking related even other diseases. But what do you think will be the role of apps or technology as far as smoking cessation is concerned?
So recently we have come up with new AI powered apps, which are very emerging, and they're very valuable tools for smoking, to fight against smoking cessation. And they usually support and they guide the individuals who are willing to quit smoking. So main factors which are covered in these apps are usually they have a personalized support, like how you talk to your friend if you want to stop smoking, where they give you a lot of guidance and all. These apps are all like that. They're very friendly, personalized, and as if some person is talking to you, and it is more motivating. So and it also has some real time craving managements are there, and it has an algorithm. If you're planning to quit, when you enter into that, it gives an algorithm. If you have a craving to smoke, it will suggest you to do some small activities like have a 5-minute walk, try to deviate your mind, try to listen to a song. So it has some craving management techniques, and it gives some algorithms to people who wants to try quitting smoking. And there are a lot of motivational supports in these apps, and they give a lot of accountability. Integration with other evidence-based techniques like using tobacco chewing gums or this sprays, nicotine sprays or nicotine gums and all. The other techniques also will be incorporated within the apps, and they suggest you to keep using that if your limit is crossing, or if you have cravings more number of times, So all these are usually combined together into these apps. And one free app that has been released in Jan 2024 by this Fred Hutchinson's Cancer Center in Seattle, USA. They have been doing research for last 6 years, and they have come out with a free app which is freely available for everyone around the world. It can be used in Apple and also the Android. So these apps usually they help you for 2 weeks before planning for quitting smoking, and they usually support you 4 weeks after quitting smoking. Also, they'll be helping you to get rid of this cravings and all. So this app is named by QuitBot, B-O-T, QuitBot. That's a free app which is available online. And in this, there is a character or an avatar, a person called Ellen. Ellen keeps helping you. Whenever you have any craving and all, you can talk to Ellen. You have a chat box and all. If whatever you're feeling, what you want to know more, you can chat with the person. It's like talking to your friend. And this is very famous, and it's been used in US most commonly. So this is one common app which is available, and there are a few other apps which are very famous, like Smoke Free app. That is more famous. It also helps in quitting the smoking, and in that it has delivering mission and takes back the feedback from the patient. It tells you one suggestion, and it takes how are you feeling, are you going ahead and all. It takes the feedback. So it's a dual side. It's not a single side. You see the app, you go read that, and you do. It's not like that. It's more interactive, and it's a double side app and very useful. And a few other apps by Quit Genius app and Crave to Quit. These are also two famous apps, and these are also very interactive. Always you need a lot of motivation for smoking cessation. So these are the good available interactive apps which are available. And the remaining other three apps are they're with payment only. And only this QuitBot app is only free for service.
Got it. Amazing what all technology can do, right? I mean, now, right from, AI in COPD, now we've got digital friends also, who will help us quitting. So let's hope all of us or make use of these apps, and, the patients are benefited from this. Now I'll move on to Dr. Jaykumar next. Dr. Jay, obviously you gave a wonderful talk. One of my problems with you is that you are restricted to Ahmedabad. See, you are one of the most famous pulmonologists in India. Now there are people from Bhopal, there are patients from Hyderabad, all over, let's say, who have read about you, who know about you, who want to avail of your service. Do you think in this current era of telemedicine and apps, do you think you can leverage technology to bridge the diversity in India?
I think, Kapil bhai, it's a very important and pertinent question. Let me first and foremost thank you so much for your kind words of appreciation. And then let me move to my personal journey. Why I got interested so much in telemedicine, telehealth. It was around 10 years back, where there was a patient coming from the African regions. And I diagnosed him that the patient is having obstructive aortic, and then we kept in a loop with the email. And then one day he sent me ECG, and it was showing abnormality. That gentleman didn't have access to cath lab. And then I told that you rush immediately as far as possible, and then he could reach within 1 or 2 days, and then he had a blockage. And that intrigued me. That told me that the patients who are at remote areas, I can be helpful to them by giving such advices and guiding them. Even though it was a cardiac case, extrapolating that to the COVID, when we all were practicing one or other form of teleconsultations. And the telemedicine practice guideline came. The first telemedicine practice guideline came in 2020. I saw a big opportunity. Before that, there were two platforms which I was inspired. First was obviously oncological setup by DMH. And they were giving or offering second opinion. And one was in our field, Dr. Prashant Jhajar, sir, who were giving the second opinion on the these things. So that part, during 2021, there was quite a good laid out foundation of medical laws and ethics. And first and foremost is the teletriage. So what I have found, I have been practicing tele consultation since then. Two things I would like to tell. First is, see, it should not be a tool to make money. It is one thing where you want to give very good professional services, And what I have found is if I can connect to a healthcare provider at a remote place, I can guide them better. So this is first and foremost, if not a healthcare provider, like I cannot market teleconsultation that I'm doing COPDs and just put a Facebook algorithm that show it in Indore or show it some regions of Orissa. No, it doesn't work like that. If patient can, it largely depends on the patient's education level too, and what their realistic expectations are. So at personal level, I'll be like to communicate with the healthcare worker more and guide them. Like I'll give you a real life example. When this COVID things happen, when many of our patients were stuck at Bhuj who cannot travel because of these limitations. So there was a marketing agent who was sitting there, who was even translating what the patient was telling. And based on that, I was giving them advice. They were giving me the consultations, new cases. And I think this is the biggest opportunity. First is that it has to be, this teleconsultations has to be given in a good faith. And that is where the context comes. First is teletriage. You tell that this patient doesn't require teleconsultation. First, take this patient to the hospital. Patient is gasping. Patient is requiring oxygen, BiPAP support. Tell them no need of teleconsultation. Go to a nearby hospital. Second, even if some person requires teleconsultation, I think you can bridge a gap with educating the healthcare professionals, particularly in cases of COPD, because it will be a long-term process, and every time you cannot be there to assist. If somebody is from rural area is contact me, I need to tell them to contact your primary care provider at a nearby. And a third and very important thing is that you have a rapport with the registered medical practitioner at the local place who can, whenever he or she is like what to inhaler, whether to give oral steroids, when to give vaccination, you can just educate them. So I think definitely yes, but that the teleconsultations and telemedicine has big advantage that we can definitely bridge the gaps, but it has to be a proper channel. And within the context that we should improve the patient's life with this thing, sir.
Okay, completely agree with you. There has to be a proper channel, but it will help in bridging gaps. And I'm sure a lot of patients all over India will be able to avail and, communicate with you and, use your valuable guidance. Now I'll get Dr. Mahesh in. Now, Mahesh, you spoke about tele rehabilitation and a lot of tele, facilities. Now, according to you, how can apps or AI help doctors in routine COPD management? Do you think it's time to incorporate AI in our routine OPDs?
I think personally, if we ask many of the chest physicians, most of them at the beginning of your panel discussion, you had asked how many people are using AI in a routine practice. I
Correct.
think very few are practically using, and actually this is an evolving phase. And as Dr. Aditya had mentioned, that we have to embrace the AI. So unless we start using AI, we will not we will not evolve this technology, and our technology like machine learning, there are some deep learning algorithms, they will not evolve. So I think we should start incorporating the AI into our practice. As Dr. Sindura had mentioned about that QuitBot is one of the free tool which is easily available for us. So as of now, we are not aware of the many tools which are available for us to use, and we are not that tech savvy that we are using it daily. Apart from this, we also do not have that much of health, that much of technical infrastructure as of now in India, that doctors as well as the patients, most of the patients don't have access to internet. So this is not the time where we can go 100% with the use of AI into a routine practice, but I think we can start using the many apps. Dr. Jay had mentioned many apps, many programs, many tools in his presentation that we should start incorporating into our routine practice. And actually what it requires the enhanced workflow, and it can also even assist, this AI programs can assist us in some of the administrative tasks like giving an appointment, follow-up, tracking the patient, taking the data from the patient where the patient has, like there are some smart inhalers are there in use. So if patient is not using, the physician can have an alert that this patient is non-compliant with the inhalers. Even the patients can also get an alert that this is the time when he's supposed to use the inhaler. So if we combine everything, I think we can have a better patient management, and this should have a personalized approach that as as we know that one thing doesn't fit to all. So we have to see which patient can utilize this kind of things, and if we combine everything, I think it will lead us for the better patient care management.
Correct. I completely agree with all your points, and I do agree with the majority point which you made. You know that this is an evolving branch. This is an evolving topic, and this is where I love today's panel discussion, because trust me, I myself am learning so much from all of you, and I'm sure that the listeners who have logged in will also learn. There is a lot of scope of improvement, and all of us will need to change our practice. Thank you so much, CCI, for such an innovative concept. Now, in your talk, you also did mention about medication. You know, you can use apps for reminding patients about their medication and all. So I would like to put this question forth to Dr. Aditya. Now, see, Aditya, in obstructive airway disease, we always struggle with medication adherence. You know, sometimes patients come and say, we don't understand why they are having exacerbation, their lung function is falling. Eventually, it all boils down to improper medication adherence. How do you see the role of AI in ensuring that there is a good and adequate medication usage by the patient?
See, smart inhalers. First, we need to understand smart inhaler का मतलब क्या है. We are talking about smart inhalers. Dr. Mahesh also talked about smart inhalers. Even I talked about the smart inhalers. These smart inhalers, everybody has a mobile phone nowadays. And what is better than audio-visual aid? जो दिखेगा वो समझ में आएगा और वो याद भी रहेगा.
True.
Smart inhaler now connected with your phone, it will give you the distribution of the medicine in the specific lung sites, minimizing the wastage reduction and the adherence of the drug or adherence of the inhalation medicine given to the patient or not. And it is also going to notify the doctor that the patient has lost the track of taking the medicine, he has skipped his medicine, and the patient is nearing to the exacerbation. So बहुत सारी चीजें हैं which AI is helping. We are only feeding the data. हम लोग इनको डेटा दे रहे हैं, सारा डेटा दे रहे हैं, मान लिया. Everybody is fighting कि डेटा नहीं देना, but it is going to help in turn with us only. Patients getting a personalized reminder कि ये सुबह 4 बजे, सुबह 6 बजे लेना है आपने, या सुबह 8 बजे लेना है, और एक बार रात में 10 बजे लेना है सोने से पहले. पेशेंट स्किप कर जाते हैं. We are having majority population that is geriatric. They don't adhere with the medication. घर के अंदर कोई बच्चा होता नहीं उनको सिखाने के लिए, समझाने के लिए. Cipla has given that QR code on the top of the fora called Synco Breathe. उससे My COPD app खुलती है, उसके अंदर they are assisting the patients how to take the inhalers, proper inhaler technique, video technique. As I said, audiovisual technique is the best. So patients are getting the view of how to take the inhalers, then correct inhaler technique is being delivered or not, that those smart inhaling devices are going to confirm, right? And the second is the adherence classifier and the predictive analysis, which these AI tools are known to be doing. They are going to predict the exacerbations. If the patient has lost the track of his inhaler and पिछले 20 दिन 25 दिन patient ने नहीं लिया, and now he's having that smart watch which is detecting his heart rate is increased, respiratory rate is increased, patient is having something going on with his vitals, and they immediately notify the patient that you are nearing to an exacerbation, you need to take your inhaler and proper dosage or see the doctor. So these applications are going to help us in very good way. And nowadays, when I check the net, because it is a new topic for everybody, even me and everybody. So they are developing user-friendly apps with different interfaces in which they explain the patient how to take the inhaler, and they make the patient take the inhaler in front of the AI, and they give the patient marks and those kind of things. And so integrating the smart technology, smart device technology with the predictive analysis and the reminders, I think it is the way to go now in the current scenario.
Okay, completely agree. You know, smart inhalers and smart therapy is obviously the way to go forward. Now, Dr. Devi, I'd like to get you in again on the discussion. Now, you know, we always believe in our clinical practice that all our treatment, modalities and everything has to be very individualized. You know, every patient is different. Not only smoking COPD, we see because of pollution, we see so many different varieties of COPD. What do you think will be the role of apps and AI in individualizing the treatment for every patient?
Yeah, very correctly put. So, like, I think personally that AI or apps can help in self-management of the patients also. Like we give asthma diary, we talk about self medications also in asthma patients. So, and most of the COPD, elderly COPD patients nowadays in metros are staying alone. So these apps can really help them. If we go into common helps, as we have already discussed, they can help in symptom and PFT monitoring. They can help in exacerbation management, medication adherence, as we have already discussed. Also, they can help with pulmonary rehab and education and awareness. But if we talk about specific improvements which we can do, the most important, I think, is the inhaler technique, as we have already discussed, because most common cause of exacerbation is either not taking or not taking properly, either of it. So that is very, very important. As we have already discussed, it can help with smoking cessation also. There are now many intelligent O2 concentrators which can adjust the oxygen flow as per the requirement, as per the activity level. We all know that only smoking cessation and oxygen inhalation can improve the prognosis in COPD. So this is a very important AI tool which can be used in patients on LTOT. I feel many apps are there which can integrate your walking speed, gait, respiratory rate, SpO2, heart rate, BP, and these can equate more or less to 6-minute walk test, and a board index can be calculated in a way, and they can tell if we need to increase the medication or change the medications in those patients. According to the sputum color, according to the symptoms, if the patient feeds in the app, we can know if the patient is in exacerbation. Many times, especially in India, for mild exacerbations, patients do not come to us.
Correct.
They manage at home. And so somehow I think now the steroid and frequent exacerbators are not used that much. But if all of us take help of these apps and the patients also use these apps, it will be a better communication and better treatment for the patients.
Okay. Perfect. So I think it will definitely help in individualizing, treatment, as you've so clearly mentioned. Now, Dr. Sindura, I would like to get you in on this conversation. Now, obviously, Dr. Mahesh did have a lovely and a very detailed presentation about tele-rehabilitation. Now, obviously, in our day-to-day practices, we do struggle with pulmonary rehab. We've got different kinds of patients, some who don't want to come to the hospital, who prefer home-based, physiotherapy, some who actually like coming to the hospital. In our practices, somehow we need to incorporate, ourselves with the physiotherapist. It's like a joint sort of a team effort. How do you see AI overcoming this?
Yeah. Pulmonary rehab has very good role in the COPD apps, actually. The main target, what we are going to achieve by applying this pulmonary rehab through apps in COPD patient is mainly improving the daily functioning capacity of the patients and increase the exercise capacity and alleviation of the symptoms and decrease in the number and severity of the exacerbations, decrease in the incidence of the depression, because they keep sitting at home without doing any physical exercise. They get more depressed and less motivated and all. And also to improve the quality of life. This is a main motto for which we are going to do pulmonary rehab via the app basis. So there are few apps which are designed, and there is one good study from Germany with the Kia app, and in which they mainly concentrate on only pulmonary rehabilitation. So they mainly concentrate, they have three items, that is customized exercise training, material, what exercise you have to do, how much time you have to do the breathing exercise and all. They have modules or chapters, like 13 chapters. Patients should be keep on watching them so that they get motivated that they should do exercise, why they have to do exercise and all. And the third module, what is there in that app, is breathing exercises, relaxation or meditation, which improves the psychological symptoms and all. So this types of apps might be useful for the COPD patients for improving their understanding about rehabilitation and everything.
Okay.
So these apps usually they initially take up what are your symptoms, what exercise you have to do, and how much duration you have to do. You can choose the duration of the exercise also, 5-minute, 10-minute, and 15-minute exercise durations, depending on the severity of the COPD. Those who are on long-term oxygen therapies and all are excluded in these apps, in these rehab apps, and because there is no oxygen monitoring and all during the exercise, so they are usually excluded to use these apps. So after doing the rehab and all, they frequently have some assessment within the app itself. So it has COPD assessment test score is there, and 1-minute sit and stand test. These are the two assessment tools that are used in this rehab app in COPD patients. Once that has improved, then they will go to the next level of rehab. Once it is deteriorating, patient is not coping up, symptoms, assessment test has lesser score, then they reduce the exercise requirement for that patient. That is how the app itself, it will decide whether the patient has to do 10-minute exercise or patient has to do 5-minute exercise, depending on the two assessment tools, that is a COPD assessment test score and 1-minute sit stand test. So I think this type of apps will be useful for the patients.
Perfect. So amazing. I think I'm learning so much, from all of you all. I'm going to repeat the statement, I think, after every 3 to 4 answers, because it's a really interesting discussion which is going on. Now, Dr. Jaykumar, my question to you is, in your presentation, you did speak about, spirometry, which is being measured via an app and the patient can do it at home. Now, for example, I personally have got an issue with this because spirometry, as we all know, it's a patient dependent procedure. It's also a technician dependent procedure. So now we've got two scenarios. One where the patient comes to us in our OPD to do a spirometry and we can be assured of a quality spirometry. And the second is a patient is at home, which probably they will prefer. Now, what is your thought process on the difference in both of this? And in your practice, what do you prefer?
Sir, I completely agree with your stand because PFT, spirometry, is basically an effort-dependent test. If we tell someone to just directly get the instrument and switch it with a Bluetooth app, so that person will not know how much to be do. It's like if a person, a novice person, a person who is doing spirometry for the first time, he will not be able to understand how much to take or take a deep inhalation and how to do forceful exhalation. It's simply not possible for them to comprehend. However, once a patient who has done spirometry a few times, spirometry test few times under your supervision, under your quality technician supervision, you may still risk doing spirometry at home. Now, one of the most important takeaways is from what I got is from the transplant specialty. Many of our lung transplant patients, we give them vitalograph that gives us FVC, FEV1 and ratio. And then they are so much acquainted with and comfortable with the lung, like respiratory problems. They can easily do that, give our WhatsApp data, and then we can manage the medications accordingly. Most important part in such patient is that we need also to prevent the infection. So hence, if we can give them this vitalograph, again, vitalograph is a small portable device. It's not connected to some smartphone. It just gives the inbuilt data. So I have more experience of this vitalograph, and the persons are really like lung transplant recipients and all who are very much knowing this lung physiology. But to someone who is very novice, particularly the patients like COPD who are frail, if something happens to them at home while doing this, I don't think it's a good idea to get the spirometry-based interpretation done at home in COPD patients, particularly in the elderly, frail patients with the COPD. So my take is very clear. I completely agree with you, sir. Hands down, if the patient is requiring spirometry, it has to be done in the doctor's cabin under the trained technician. And except in such scenario where the patient is very much educated, acquainted with all these diagnostic procedures, then and then you can take some risk of doing spirometry at home and interpreting those values.
Perfect. I completely agree with your answer. In fact, just to slightly divert from the topic, Post lung transplant, as you mentioned, this is something which we definitely use after adequate training. Not only does it help us in picking up early infections, but early allograft dysfunctions is something which we pick up. And like you mentioned, if there is any fall in the home spirometry, we urgently call these patients to our clinic to have a supervised spirometry done, because that is more of a quality sort of a control. So I completely agree with your answer. Now, Dr. Mahesh, I would like to again ask you this question. Now, see, we've got so many apps. We are monitoring blows, spirometries, tele rehab, so many things. But how do we keep a channel of communication open between, the healthcare providers and the patients, via these apps?
So this communication now has become very faster with this digital technology and the way mobile towers and everything has been set in India. Of course, we have seen that previously in 20 years back, there used to be only a physical mode of consultation, where to consult a doctor, patient has to take an appointment and physically consult a doctor. But all this electro communication, all these communication devices, we can immediately contact a doctor in case of emergency or in case of some doubts related to disease or treatment or medication, etc., etc. And there are multiple apps which we have seen that we have discussed in today's our webinar. These apps cut shorts the duration, cut shorts the time required to consult a doctor. So there are two things. That one way that patient can directly contact the doctor on phone, and there are some indirect communication measures for doctors, like Dr. Devi mentioned about the smart oxygen concentrators, there are smart inhalers. There are some apps which will immediately let us doctor know that how the patient's sleep pattern, how much distance patient is walking, what is the pulse rate, or what are the daily parameters revolving around his vital parameters like pulse rate, respiratory rate, saturation. And with this indirect communication also, doctor also comes to know whether patient is improving or patient is deteriorating. So with this digital health, I think this time duration has really decreased between a doctor and patient, and we are going ahead with improved management.
Okay, lovely. So yeah, I completely do agree with you. It's very important to keep this communication channel open. Now, Dr. Aditya, I want to ask you this question. You did mention it previously in your answers. See, one of the things which we absolutely hate in COPD is basically exacerbation. See, we love our patients. We want the patients to come to our OPD. We would love teleconsultations, everything. We don't want the patients to go to the ICU, because obviously then it's like a downward spiral in their natural trajectory. So when we talk about exacerbations, if you could once again explain how are these apps and smart devices and everything helpful in recognizing early exacerbations?
So now, Kapil, I was only stressing upon this tracking of exacerbation again and again because this made me a little wary that how these are going to do that. This is what I read, and that is why I'm again and again trying to make importance of. So, like Dr. Jaykumar said now that they are putting in their symptoms, they are logging on their vitals. So when you are putting the symptom and in the applications, if you do it in the application, it is automatically going to be tracking your symptoms, which is going to in future give you patient related outcomes. And when they are connected to the healthcare people, so they are going to give the alerts to both that the patient is also going to land up in exacerbations, and even the doctor that your patient is so and so in going into exacerbations. Even these wearable devices, these are monitoring SpO2s, they are monitoring the lung functions, the saturation, the heart rate, the activity levels. And whenever there is a significant change in the picture of the vitals, it immediately gives the alert. So these kind of apps they are developing, and there is a Journal of Medical Internet Research on 2025 that has been published, which is giving out these kind of things that they are developing these kind of applications, wearable devices, and they are incorporating. So every year Apple Watch comes out, every year Apple iPhone comes out. They are incorporating new and new applications in the Apple, and this is going to be the next thing in the Apple Watch is that saturation is going to be maintained, the heart rate is going to be monitored. It is already being monitored. Then the telemonitoring and the decision support dashboards they are being developed. Now, what is the dashboard? If you see your iPhone, your phone, there's a dashboard on which there is daily log of how many people have visited your profile, how many things are going on. So there's a dashboard of the symptoms that is going up and down, which is in real time monitoring. And this is going to be a new thing like CGM. It is going nowadays being used. The continuous glucose monitoring is being used, like the body patch is being used. So these kind of things, they monitor it current in real time. Whenever you open your phone, you can see your symptoms, what are they going on, what is your breath rate, what is your saturation, and everything. So these are going to help in the symptom tracking. They are going to help in the patient related outcomes, and even the education of the patient to prevent exacerbations. How can they handle their exacerbations at home? That whenever this is going up and down, an alert has come. Now I need to take my medication, even call my doctor, go to the clinic or go to the hospital and get myself recovered. थोड़े में वार्ड में एडमिशन में बेटर देन कि आईसीयू में लैंड अप हो पेशेंट. सो ये पेशेंट को भी समझ में आता है व्हेन ही नीड्स टू शेल आउट लाख ऑफ रुपीस फॉर द आईसीयू एंड हजारों में काम होता है वार्ड में, तो ही गोज टू सी अ वार्ड एडमिशन. सो दीज काइंड ऑफ थिंग्स आर बीइंग डेवलप्ड. सीओपीडी प्रिडिक्ट हो गया. देन ये जो अभी डॉक्टर जय ने बताया वाइटेलोग्राफ हो गया. सो मेनी एप्लीकेशंस आर बीइंग डेवलप्ड एंड पुट इन योर स्मार्टफोन्स. दे आर बीइंग फेड द डेटा, so they are going to predict the outcomes of the patient symptom.
Okay. I think I love the fact that you explain in a very financial manner. Sometimes that is what, patients understand.
बहुत जरूरी है सर, बहुत जरूरी है. पेशेंट को डराना, पेशेंट को बताना कि भाई तू सीधा आईसीयू में गिरेगा जाके, वहां पे लाखों रुपया खर्च होगा, या हजारों में काम होता है, और ओपीडी में तो सिर्फ एक आपको फीस देनी है बस दिखाने के लिए.
Correct. True. So I really hope that they understand this. This is a very important message coming out. Jay, if I'm not mistaken, you were raising your hand. You want to say something?
One more thing I want to add, Dr. Aditya's message is that even with the mapped location, like Google Map and Facebook, they both track your visit history, location history. And I read this article around 2.5 years back, where the Facebook data, they collaborated, not in a COPD, but with the asthmatic patients. That visiting such and such place, after coming there, you have got an exacerbation. So next time you can have this in your mind, that visiting such environment areas will lead to flare up in your respiratory conditions, and hence you better avoid that. So I think not only with the symptoms, but also with the location history, the map history also you can prevent the exacerbation.
I am just afraid that in a city like Mumbai, you step out of the house, I think the location, will get flagged up. These patients will land up with exacerbation. But, that's a lovely point. It's a very interesting concept, using location history and, mapping your exacerbations. Now, Dr. Devi, I just want to ask you, see, now sometimes we've got patients who are very different. Some patients, and a lot of them want information. See, this is an era of Google. So patients log into the app not only for recording their own vitals and all of this, but they want information. And this can vary. Some people want to know what is COPD. Some people want to know what is e-cigarette or vaping, whether is it safe or not. Some people want to know what is rehabilitation. So there are so many things. So how does AI or technology help a patient in this?
Yeah, very correctly put. 5 years back, we were seeing that the young people were using these apps and these Google and everything more. But nowadays, we also see elderly people who they are using a lot of AI or internet stuff, and they need information and awareness. So through these apps or through Google or through AI, they can have access to information about like symptoms. They can have medication reminders, inhaler technique guide, exercise program guides, nutrition guide, which are very, very important aspect of COPD, because all of us know that COPD is not actually limited to the lung. It behaves more of like a systemic disease with many comorbidities and all. Very importantly, as we have already discussed, it can also facilitate communication and support, like to the caregiver. It can alert the caregiver, and he or she can intervene at the point of care. Healthcare provider communication has already been explained by Dr. Mahesh. Peer support, which is very, very important for these group of people, like it can have they can have a community and they can share their experiences. These AI tools and apps can promote engagement and motivate the patient through motivational messages, as Dr. Sindura has also explained that now these apps are very interactive and engaging. So this is a big help to the patient, and it can help in reducing hospitalization by early detection of exacerbations and improving the medication adherence.
Okay. Okay. Dr. Sindura, I've got a very difficult question. Unfortunately, you are in the line of fire. I want to ask you, what are the current regulatory frameworks, of these apps, whether they are present? If yes, what do they say and how do they impact such apps?
So these mainly concern to COPD. These apps are still in developing stage. So one main constraint in respect to the telemedicine is you cannot change or you cannot prescribe newer drugs online or psychiatric drugs and all. You cannot change the prescription. If already taking inhalers and all, you can increase or decrease, but newer prescriptions cannot be prescribed as one of the exclusion criteria in the telemedicine guidelines, which is available in India. So what are these main apps? Mainly they're intended, or mainly they're focusing on whether the patient is taking the inhaler techniques properly or not, whether pulmonary rehabilitation is going properly or not, or whether there is a good integration with clinical care, whether patient is taking proper medications on proper time and all, as we have already been discussing regarding that. And symptom tracking and management. These are the only four main things that are being focused in COPD. So what are the challenges, where it is going to lead, what are the future directions? There are a lot of lack of specific regulations. There are nothing specific regulations available at this point of time. There is no clinical validation. Even it gives FE1, how far it is correct and on what basis it is going to give. There is no clinical validation, or there is no studies which are available at this point of time. And how about the quality maintenance, whether it is sensitive, specific, or how is the quality of all the apps also, it is not known at this point of time.
Correct.
So unless it is user friendly, patient adherence for longer time, long-term use to these apps, if it is feasible only, we will know how it is going to be validated, whether it is going to be useful in long term or not, we will be knowing in future.
So I completely agree. A lot of unknowns, as far as regulatory frameworks are concerned. But I think if we start embracing this, we will have more data, more research will be done. Probably 3 to 4 years down the line, we will probably be equipped with better regulatory frameworks, is what my takeaway is.
Yeah.
Now, Dr. Jaykumar, I'm going to ask you a very lovely question. I know that Aditya touched on it. And, I know that this is a very important topic as far as our country is concerned. See, the economic condition of a patient is very important in our country as far as methods of treatment and all of that is concerned. Okay. So this has to be discussed with a Gujarati, because remember, we are all novices. You are at the top of the chain. Okay. So you need to tell everyone, you need to coach everyone, what will be the cost, benefit, and the economic savings as far as patients are concerned, when they're using these apps.
So first and foremost, about focusing on the telemedicine and the teleconsultation. The telemedicine practice of India guidelines, they categorically tell that you can charge the same what you are charging for your in-person consultation. So having said that, there is not much difference of consultation fees which patient has to incur, whether they are seeing in person or via teleconsultation. However, I was going through one study where they have done the cost benefit analysis of the patients in the tribal and hilly areas who are coming to the main Tier 1 cities. So this study is basically conducted from Rajasthan, Abu Road and Sirohi, who are coming to the Ahmedabad. And see, they have divided this cost between direct like consultation related cost and indirect cost. Like mainly it's a transportation cost. So if you are coming from the hilly or tribal areas to the main cities, the transportation, it takes time, plus it's costly. Again, they categorically divide into three, using public transport, then carpool, and then the private vehicles. Obviously, private vehicle will be more costly to them. Again, a person will not only come, a patient will accompany two or three more persons when they are coming from such. So this cost increases, the indirect cost increases. Again, the cost of food one has to bear. In short, they have told that the teleconsultation, when you are providing teleconsultation services, the doctor charges remains the same. But indirect costing like transportation, food and all, you save at least 1500 rupees to 1600 rupees if you're coming from a distant area or hilly and tribal areas to Ahmedabad. So I think that can be extrapolated to many other regions too, that while doing teleconsultation, we will be minimizing this indirect costs. Coming to the direct cost, like if we can see that the patient is doing good and patient doesn't need any tests, so that cost can be saved. And again, as Dr. Aditya sir rightly mentioned, that by doing minimal charges of teleconsultation fees to the doctor, you can prevent a big exacerbation, because a doctor can see you with the audio-visual teleconsultation and can get the idea of exacerbation or flare-up early than the patient feels himself. So I think that's a very important part. Again, coming to the pharmaceutical, I think the cost is again the same. So by doing teleconsultation, we can reduce the indirect cost burden, like a transport and a food cost to the patient and their support or the caregivers. Second, unnecessary tests can be avoided. And third, by examining them and promptly telling them the patient is going to develop exacerbation or they are not doing well, we can definitely cut that the opportunity cost that the patient need to bear that. So I think yes, in appropriate scenarios, teleconsultation is a lot of cost, can save a lot of cost to the patients.
Okay, so that is good to know, because patients will ask all these questions. These are more practical questions which I think all of us face in our day-to-day practice. Now, Mahesh, we live in a very funny world. Okay, nowadays you see you've got tech giants like Facebook and Google. All of them are regularly sued by people left, right, and center because of one thing, and that is data security and privacy. Now we are talking about apps, we are talking about patients. This is going to be something like a third party. They will have access to so many parameters. Do you think data security and privacy issues can also arise as far as these apps are concerned?
Kapil, you had raised a very important and pertinent question, because data security and data privacy, these are the two major concerns when we are dealing with this digital health in India. And actually, India requires a robust framework for this data management and a lot of laws pertaining to it. Also, if you know that a few years back, one of the premier institute of India during the COVID time had a cyber attack. And during that time, that institute had lost a lot of data. I don't want to name the institute, but it had really happened, and it did not happen to a smaller institute. It happened to one of the most premier institute of India. So it clearly shows that there is a data breach, the security is at stake, and we really need to be aware about this kind of things, because as you know, if when one is using latest mobile, latest software with updated firewalls, etc., then we have a less concern of data breaching. But when we use a public network to access such things, or mobile is not having an updated antivirus, or if suppose now you want to track how much distance you are walking, or you wanted to use some of the parameters which are being given at a very higher price. So there are some apps which will provide you this for the free, but they will have an access to many things. They will have an access to your camera, they will have an access to your microphone. So from here, your passwords and everything will be online available for them to hack your mobile, and your data will not be secured. So in this thing, we should be more aware, and I think doctors has to also take care of this, that the data which he is collecting from the patient should not be available freely online to these hackers and everyone. So this is really a major concern, and I think as we move forward, everybody will be educated, and then we can minimize such mishaps.
Correct. Completely agree. This is a major topic. That's why I decided, to incorporate this question in today's discussion. Let us just take a pause from the panel discussion. I think we've got some questions which have come up from the audience. So there are 3 questions. So I'll just ask this question, and anyone from the 5 of you can answer this. Okay. So the first is a very interesting question. Dr. Sushma Duggad ma'am from Nasik. She is asking a lovely question. Will AI replace physician? Aditya, go ahead, answer.
Boss, I have been explaining this since the starting of the webinar. These applications, this AI, this is going to complement our practice. It's not going to replace it. It is artificial intelligence being fed by the human intelligence. So we are feeding this, making it smart for our use. We are not going to be tamed by artificial intelligence if we want to think about the clinical thing. Right.
Correct.
Everything he said, Dr. Jansari said about data breach and everything. But we have been filling our data in our applications since 2011, 2008, since we got the smartphones. Myntra के अंदर आप अपनी सारी data डालते हो, Amazon के अंदर अपना सारा data डालते हो, Alexa सब कुछ सुन रहा है. We all know that. So why not they help us in our clinical practice also? भाई अलेक्सा को आपने सब कुछ बता रखा है. अलेक्सा से पूछो वेदर क्या, भी बता देगा सारा वेदर कैसा है, पोलन कितना है, कितनी ह्यूमिडिटी है, आपको क्या पहनना है, क्या नहीं पहनना. इट गिव्स यू एवरीथिंग. So it is not going to replace you. It is going to complement your clinical practice, help your patients, help you out, and going to keep your patients with you. They are going to keep your patients engaged with you, and loss to follow up will be less.
Correct.
So that fear हमारे को निकाल देना चाहिए. That's what I was talking. We don't need to fight it. कि हमें डेटा बचा के रखना. जब आपने नेट पे डेटा डाल दिया, वो नेट सब चीज, हर चीज, सब इंटरनेट पे सब कुछ सबका है. कोई रोक नहीं सकता. कोई भी डाउनलोड कर सकता है. कोई भी उसका यूज कर सकता है. So be wise and put that data that is publicly accessible and you don't have any problem with it. Like symptoms डालनी है. पेशेंट का आपने लॉगिन डाला, पेशेंट की एज डाली, पेशेंट के ऑक्सीजन स्टैट्स डाले, PFTs डाले. I don't think there is only going to be any security breach for that. In turn, it is going to help your patient get monitored. In turn, it is going to help your that dashboard being monitored, and you are also going to be in touch with your patient. That patient is not having any exacerbation or those kind of things. So don't fight the system because it is here going to stay. It's not going anywhere. You can't fight it. It is slowly seeping in your practice. It is slowly seeping in your laptops, computers. Everything is now guided by AI. Even when we are typing, it gives the autocorrect facility. That is also AI, nothing else.
True.
So we need to embrace it. We need to use it for our clinical practice, and we need to be happy with such kind of technology has arrived in our time. पहले नहीं था, अब है. So we need to use it.
Correct. So I agree with you. We should not fight it. We should embrace it. I think Dr. Devi also wants to add something. Please go ahead, ma'am.
It's high time that we think AI as not as an intruder or a competitor, but as a multi-talented assistant who can help us deliver a more precise, economical, integrated, equitable care to the patient. So it's
correct. Complete. Mahesh, please go ahead.
Now, everyone, including the engineers, doctors, and everyone is feeling this threat that AI will replace the human. AI can replace a bit of human intelligence, but it cannot replace the human touch. So now you see, using an artificial intelligence without an human intelligence will create a lot of problems. I'm talking from the patient's perspective, because we have come across many patients that they have gone, those we call as Google doctors. They go to Google, research, they take the medications, and in a way they come to doctor when their problem is increasing from mild to a severe stage. So this clearly shows that as of now, artificial intelligence cannot replace the human intelligence, and it can only complement us to manage a patient better.
Correct. So at the end of the day, artificial is going to be artificial, and we've got natural intelligence. So let us leave it at that. Now, the next question is also very interesting. How can we differentiate asthma and COPD? Anyone can answer.
So you meant to say asthma and COPD with respect to an artificial intelligence?
Yes, with respect to artificial intelligence, with respect to apps, technology, how can you differentiate?
So now clinically, all of us know how to differentiate between the COPD and asthma. But as Dr. Jay also mentioned that in Facebook, suppose there is one patient who is traveling from one place to another place, and recurrently he's getting an exacerbation at a specific place where there are high quantity of pollen, or where there is a high air quality index is very poor. So it clearly shows that this patient may be having asthma. So if we go, there are online tools are available where if you put your symptoms, it may give you a little bit of hint that this patient may be having asthma or COPD. But
Correct.
to clinically confirm it, you require a human touch. You need to consult a doctor. Only based on an artificial intelligence, it will be difficult for a patient to differentiate between asthma and COPD.
So correct. It's almost like an extension of the previous question. We need natural intelligence, obviously, to differentiate. Apps will help us, but obviously we need a clinical touch. Dr. Jay,
This data will be analyzed by a doctor, and then he will give the conclusion कि वो अस्थमा है या COPD है या अस्थमा overlap syndrome है. ये patient घर बैठे जज नहीं कर लेगा और treatment नहीं कर लेगा. So that is where human intelligence walks in.
True, I agree. Dr. Jay, you also want to contribute something?
Yes, so my take on this is it's very important question that how to differentiate it between COPD and asthma. Let's talk about COPD. Like around 200 years back when Sir Laennec introduced this stethoscope. I think we are the only specialty who are routinely using stethoscope in our practice. But does he ever had in his mind that, did he ever had this in mind that COPD will be defined as FEV1 FVC ratio less than 0.7 and this will be gold standard. It will be in entire, so then the computers came in and now we are defining COPD. One of the defining features is FEV1 FVC ratio less than 0.7. It's a spirometry data. It was not available at that time. Extrapolating that, sometimes like I told, we have to incorporate this AI data. Probably in next 10 or 15 years, we might be having this cough signatures. We might be analyzing this phonocardiogram signatures that this is the amplitude, this is the frequency, and we might not even go to the spirometry. With the help of just cough sound and the oscillatory signatures only, we can differentiate that this is COPD and this is asthma. So I think we are moving probably on that direction. So I think that is how we should approach it. And like we are analyzing spirometry data routinely in our practice, X-ray routinely in our practice, blood test routinely in our practice. At some point of time, we may need to incorporate this AI and app data also, that what they are saying and what they actually mean to get the meaningful ideas and to treat our patients better.
Correct. Completely agree with you. Yes, Mahesh, please go ahead.
I'll just reiterate one of the professors where I have worked with, Dr. N.T. Awad. He had a very typical saying that guidelines should always be read in light of your clinical experience. So similarly, our clinical diagnosis is different. You must have seen that many patients, their PFT parameters are looking like a COPD, but then clinically we know that this patient is behaving like an asthma. So all this app, all this AI, everything, this is a complement to our clinical scenario or to our clinical decision. So it is not the only thing which will differentiate between it, but it will help us to, it will complement to our clinical diagnosis.
Correct. Completely agree. And the third and the final question, which I want to ask the panelists, again, it's a very important question. Again, this is by Dr. Sushma Dugard, ma'am from Nasik. And she is talking about the increasing geriatric population which we have in our country, and also the concept of nuclear family. So people will be alone. They don't probably understand smartphones as well as probably you and me. They don't access it as much. So for this particular kind of population, how will apps and smartphones and all help? Yeah, Dr. Devi, please go ahead.
Tier 1, Tier 2 cities, most of the elderly are using smartphones and they are using internet, and also it's not a big problem for them, I think. But yes, in villages or in peripheral areas, many elderlies are not using. But through AI, we can have a caregiver tool. So they can be the middleman between the patient and the experts.
Correct.
So that can be done, I think.
Correct. That definitely can solve a lot of problems. Okay, perfect. So I think let us continue with the panel discussion. And if there are any more questions, we can take it in between. Dr. Aditya, what do you feel? Research and clinical trials, they form a very important part in routine clinical practice. Do you think using technology will help us in research and all of these clinical trials?
As I told, we are feeding the data ourselves. So these applications, we are collecting vast amount of data from the real world diaries, and they are going to implement them in your clinical application. The physiological measurements from the connecting devices, the medical adherence, the symptom diaries, these all are going to be collaborated and going to give out an efficient data collection. Then enhanced patient engagement, the patients who get lost to follow up, patient who's don't adhere to the treatment, they are also going to be included in those data entries. Even these, there are projects like Healthy at Home. They are going to utilize the applications for digital consent and enrollment alongside biometric and the symptom tracking. So MedRex 5, they have not given out their research in 2025 only. And even the My COPD app, which I was talking about, this has been floated by the NHS to support remote management and reduce emergency admissions of the COPD patients, which is a very big burden for the economy.
I think you are audible.
Aditya, your audio is not.
Yeah, now we can hear you. Go ahead. No, it's not coming. Okay, I think anyway, I mean, while the audio is sorted, I'll come back to Aditya on this. So we'll just move on. Dr. Devi, I would like to ask.
Can you hear me?
Yeah, now we can hear you. Please go ahead. Continue.
So I was talking about the My COPD application, which is being deployed by NHS to support remote management and reduce the emergency admissions, which is a very big burden for the international economy. Now, apart from this, there's a real world data that is being collected from India. Now, same applications is being downloaded in USA. Now, this data is crossing boundaries. These applications are going to collect global data and going to present their statistics that how many patients don't adhere to the treatment. It is a work of research. So University of Gothenburg has launched a Care for COPD study, which is, for instance, investigating the effectiveness of the digitized care plans and remote monitoring of the patients in COPD with a personalized care approach. Like you were talking about, the one size does not fit to all. So personalized care is also being given to the patients with that application. So these kind of things, and what I was talking in the starting, the stratification of the population on the basis of phenotypes, biomarkers, these kind of things is going to be predicting the outcomes, different kinds of phenotypes that are working in with COPD, with different kinds of symptoms, with the tailored approach of the treatment, and it is going to help in the research and the clinical trials in the COPD patients.
Okay, perfect. Dr. Devi, I'd like to ask you, I'm biased in this question actually, because this is with regards to my, thesis when I was doing my PG. Now, we had a CCI webinar which spoke about comorbidities in COPD. And we know this is a very famous thing. COPD is not only the lungs, it's the entire body. Now, in this entire discussion, we've only been talking about apps, taking respiratory parameters and everything into consideration. Do you think we have to extend it to talk about the comorbidities as well?
Yeah, absolutely. So all these apps can help in monitoring comorbidities. Even many of us use watches, Apple Watch, Samsung Watch, anything. I use this smart ring. I'm not advocating any, but all these can help us monitor. Like most of the COPD patients have comorbidities like hypertension, diabetes, sleep apnea, anxiety, depression, cardiovascular diseases, osteoporosis. So what these apps can do is they can collect the data and track it, like through these variables maybe, or the patients can manually give the inputs. It can, or the integration through e-health health records also. Okay, and so the apps can also analyze the data and they can show the patient the trends, so they can know about their diabetes management. They can know about their sleep pattern. They can know about their stress levels. All these are very much helpful, because as Dr. Aditya has already told, if we see it, it's more imprinted in our mind. So when the patient sees that his or her diabetes is not controlled, his or her hypertension is not controlled, they tend to take better action at it. So this, and also these apps can give personalized feedback or a point of care interventions also. They can give alerts and reminders about the same, and also they can support in management through medication and lifestyle modification, all those information. So yes, they're very much helpful for all the comorbidities.
Perfect. Completely agree. Dr. Sindura, again, I'm going to put you in a spot of bother. This is going to be a technical question. I must admit that routinely in our practice, when we talk about end-stage lung disease, there's always a theoretical topic of palliation and end-of-life care, management and all of that. It's not being widely practiced, but do you think AI will sort of bridge that gap and ensure that it is being practiced?
AI has been you mean in palliative care?
In palliative care and end of life, how will AI help us?
Yeah, I think India is not so developed to use AI apps in palliative care and end of life support. First basic thing. And in abroad, in US and all, palliative care apps are being in use because they don't have anyone for supporting them for regular activities, for the household activities, or to pick up kids and all when they are palliative or when they are bedridden or something like that. So in that situations in abroad, it is being in use, and few palliative care apps are available, and end of life support apps are also available in market, but mainly they are also mainly for psychological support, family support, social support, and only it's just partial, but I don't think it is more of any medical use.
True. Agreed. It's a gray area basically in our practice, at this moment. Okay. Dr. Jaykumar, I would like to ask you, I know that what we are talking is already something which we will probably develop more in the next 2 to 3 years, but still, from a futuristic point of view, do you think there will be more things which will be added in AI?
So I think this is still a matter of speculation, but definitely we are, if we see, we incorporate from other fields like diabetic retinopathy. The AI is already doing that things. Now, at the diagnosis, the treatment, the AI model is incorporated even into the rural areas. Coming to just a couple of months back, now we are having AI-assisted angiography. So it will definitely give us the idea of where exactly we need to stent the artery. Coming to gastro part, now there are AI tools which are selecting the area of the abnormality which human naked eye is not. Although it seems like a normal mucosa, if you get the biopsy, you can get an abnormality from that area. So I think whatever is based on image analysis, AI is going to revolutionize this. I think it's very apt question whether AI can replace physicians. I think we are the like pulmonologist as having the medical specialty. I think we should not get afraid, but those who are dependent on image analysis, they are definitely afraid of getting this. Second is robotics, which are also getting trained on the surgical skills. So as we see now a lot of growth in robotics, they are getting their models trained in a way where a robot can perform surgery very well. So I think they are also getting this data from lot many surgeons who are very skilled and who are using these platforms. Just this year, the data was presented in Bronchus that even robotic bronchoscopy, it was very good talk from Dr. Pallav that there is no difference between a novice operator and an experienced operator. So what the robot is doing is reducing that experience, the decades of experience which the hand movements, the gestures which we are getting. So I think AI is definitely going to be there, as Dr. Aditya sir has told. It's not going to completely replace us because we are having lot of clinical, radiological, and data correlation. And there is a lot of human thinking, human intelligence involved as of now to decide the treatment plan and multimodality approach when it comes to COPD. But yes, in other specialties, there is a real threat. So I think the answer is that yes, we need to keep an eye how to incorporate AI in our practice. We need to stay updated with the research, particularly in the arenas where we can help the patients as much as rather than antagonizing them. And I think that's what I see the future as. I'll repeat myself that 200 years back, Sir Lennox didn't thought that this FEV1 FVC ratio will diagnose COPD. But now we have a tool called spirometry, which where we are using a fixed ratio. And then now again, we may have some cough signatures or a stethoscope signatures, which will be incorporating in our data that this shows like this and this can be either asthma or COPD. So bit of a repetition, but still I think it's still the future where we have to incorporate artificial intelligence in our practice.
Okay, perfect. Lovely answer. And my last question of this panel discussion will go to Dr. Mahesh Jansari. Dr. Mahesh, what do you think are, in a country like India, now this is a very diverse country. So what do you think are the key challenges in implementing such management apps in our country?
So the key challenges which we face during our clinical practice is education. So first, this technical education is really lacking. Our infrastructure is building, but still not it is up to the mark. And there are many patients, many people, they even do not have an access to an internet. Like Dr. Sushma Duggar ma'am has asked a question that there are some elderly patients, they are staying in village and they don't have access to internet or mobile. Then how they will be using all these applications? So it clearly shows that our infrastructure is building. Even on doctor's part also, all of us today learned so many things about AI during this panel discussion. Had I not been a part of this panel discussion, probably I would have lacked this knowledge. So we all of us are upgrading, and this is also a technical challenge that we need to upgrade ourselves. Apart from all these technical things, some of things like we and many patients, they really lack the trust on these applications because that's not a human intelligence. That's actually it's an artificial intelligence. As well as there are a lot of data security, data protection related things which we always we are afraid of such kind of things. So to combat such data protection and data privacy, there are some laws like IT law is there, one Disha law is there, even Digital Personal Data Protection Act was passed in 2023. So all these acts have been passed so that we can have a very safe, secured and protected data for our digital health. Okay. So I think it will take a few more years for us to upgrade to a next level where we can freely use this AI and all these applications and online platforms.
Completely agree with you. Yes, there are a lot of lacunae in our country, but I'm a very proud Indian and all of us are. We should be. And believe me when I tell everyone that if a country can do it, it is going to be India. I have got that confidence. And I'm sure in the next 5 years, I think all 6 of us will get together and we'll have a completely different discussion. Okay. Just one last question, because Dr. Saibra Toke has asked if anyone can just answer this. Why do we no longer use asthma COPD overlap syndrome? Yeah, Dr. Devi, please. Yeah.
So it has been found that echo, earlier it was echoes, then it was changed to echo, and now it has been removed because it has been seen that COPD and asthma can coexist, but it's not an entirely different entity when they coexist. It doesn't change the prognosis. So you have to treat according to the predominant disease, and they are only coexisting, and you have Correct. To according to your clinical acumen.
Perfect.
So I think the term is skipped from Gina and caught by gold. Now it is COPD.
Yeah.
And that is where all of us are stuck in, sometimes Gina, sometimes gold, and our entire
Sometimes good.
life is ranging between airway disease between these two guidelines. But yeah, I completely agree with what Dr. Devi said. It's more of a spectrum rather than typical boxes where we try to.
I think
Thank you. Yeah,
I
Dr.
think we
Mahesh.
can say that artificial intelligence is collecting the data on across asthma and COPD, and probably in coming few years we may get a better picture of this across.
Perfect. I completely agree. Such a wonderful statement to make. Thank you so much, my dear panelists. If I could request each of you to just give me a very short and a very quick concluding statement with regards to your thoughts of today's topic. So I'll start with Dr. Aditya.
So, I would like to conclude this webinar by saying that we don't need to fight this AI, we need to embrace it, we need to involve it in our clinical practice and get use of it. Maybe 100 years, 150 years, 200 years down the line, robots will be taming us, but apne ko farak nahi padega. We are here and we need to enjoy this AI till it
Correct.
lasts.
Correct,
Right?
correct, correct. All of us have seen Terminator. I hope it won't. So next is Dr. Devi. Please go ahead. Your concluding statement.
AI can treat a disease, but the patient has to be treated by us.
Correct.
So I think we should take AI as an helpful assistant to give better care to the patient.
Perfect. Dr. Sindura.
Yeah, with this all apps and all whatever is available, I think we should use them in our practice. We should not see AI as a competitor. We should go together with AI is what I think.
Perfect. The ever smiling Dr. Jaykumar Mehta.
So first, it's thank you so much for getting this topic, because I think only CCI can do this. This has, I think, never been in any other conferences, that in COPD. In non-interventional pulmo, we have AI and apps and telemedicine, and also a huge round of applause to CCI think tank for bringing this topic. I think this COPD series would have been left probably untouched, without this topic. And thank you so much for a beautiful moderation, Kapil Bhai, really. And I echo thoughts with my panelists that yes, we should be thinking AI and smartphone application as our complementary and embrace that in our practice.
Correct.
Thank you so much for having me.
Perfect. And last statement, Dr. Mahesh Jansari. Please go ahead.
So my last statement is technology should always be seen in light of your clinical experience. So artificial intelligence can never supersede the human intelligence, at least as of now.
Beautiful, beautiful words. So, all five of you all are echoing the same thing, that we need to embrace AI rather than fight it. Thank you so much. I must admit that I was very nervous when we started this panel discussion because my knowledge was absolutely zero. But today I have learned so much. Thank you so much to all five of you. There are a few more people who I want to thank, and it's a very important message. I agree with Dr. Jay. This is a very unique topic. Remember, this is a COPD webinar series which is going on in CCI. This is the concluding part. We began from understanding simple physiology to inhalation therapy in normal individuals. What is the management from ward to ICU. My favorite topic, which was moderated by the lovely Dr. Vijaykumar Chetty Garu, which is about COPD and its comorbidities, biologics in COPD, altitude and COPD, and to this final conclusion, which is AI and technology in COPD. Believe me, you will not even get this information in Fishman. This was so good. It was like a comprehensive look and diving deep into COPD and so many aspects of COPD. We really need to thank the think tank behind this. So many members from CCI, Dr. N.H. Krishna sir, Dr. Narayan Pradeep sir, Dr. Ashish Dubey, Dr. Anil Maske, Dr. Vijaykumar Chetty, Shivani, Atri, Ravi, so many of y'all are working so tirelessly behind the scenes so that all of us and all pulmonologists all over India can actually avail of this information. Thank you so much, MEGHMANI, for today's webinar. Two things I would like to mention. Every listener, please become a member of CCI at the earliest. Believe me, it's a very small amount which you are paying for something which is infinite access to resources, infinite networking opportunities, and infinite platform to showcase yourself. And secondly, please subscribe to CCI social media accounts, especially YouTube, Facebook, and Twitter. Believe me, it's almost like an encyclopedia. In fact, it is more than an encyclopedia. It is a library of information, something which will not be taught in routine practice and in routine medical schools. And my last statement, it could not be possible without such wonderful, smiling, lovely panelists. Thank you so very much, all of you all. Thank you, Aditya. Thank you, Dr. Devi. Thank you, Sindura. Thank you, Jaykumar. And thank you, Mahesh. Thank you so much for such a lovely discussion. Take care.
Thank you.
Thank you. Thank you so much.
Thank you.